Well, thank you, Roger. This is kind of fun. As a retiree, I come back and see all my friends. And you're still here working, and I'm not. Okay. I would like to have, where's the panel? Lisa and John, come up. We had a mishap. Our third panelist was unable to attend, so I tried to get Norm to fill in, and he cowered out. He said he didn't know enough. So anyway, we're going to have Dr. McEachern from Pacific Source. So we're going to be talking about value-based, and what I thought I would do is run through a few slides that we've used over the years. It's still valid today as far as the business case for payment reform. There's a little redundancy with Dr. McInnes's talk because, of course, we're talking about the same topic. We live in an environment here in Idaho that's predominantly driven by fee-for-service medicine, and in no way am I demonizing that system. It was engineered to do something very specifically, and it does it real well. It drives up costs and drives up utilization, and has for decades. The best definition that I've seen for value-based is that value is created when costs are reduced or quality is increased. Measuring quality in healthcare is a very easy thing to say. It's very difficult to do. So while it's a simple statement, the ability to measure it is a challenge. So when we talk about the healthcare system in the United States and in Idaho, we are very proud of the fact that we spend more than anyone else on the planet. Up to generally 3 times more money is spent on healthcare in the U.S. than the global average. And this number is a few years old, and it's only continued to rise. However, outcomes have not been so good. I think recently, last year was the first year that life expectancy for citizens in the U.S. plateaued and is now starting to decline. We have a significant problem with infant mortality, which is rather bizarre because that really shouldn't happen. And in other nations, they've resolved that issue. And we have a lot of people dying from diseases that are easily treated, yet they are not being treated because of a huge disparity in the distribution of healthcare services. And then we have chronic disease. Diabetes, hypertension is gripping this country, and I think as long as the food industry reigns supreme, this isn't going to go away soon. So as we look at healthcare spending, the best comparison is against the country's gross domestic product. And the top line is the United States. We have been, since this chart starts in 1980, we're about 8% of gross domestic product. Well, this chart goes through 14. It was pushing 17%. Well, I believe it's over 18 now. The other countries have modified that and are still below 10%. Still have had a rise, but clearly in the U.S., driven by fee-for-service, we have continued to spend. Now, I remember back in the 70s when it was Ted Kennedy, he was saying that, this country is going to go broke because we can't afford to spend more than 6% of gross domestic product on health care. Well, he was totally wrong. And I don't think we're there yet. Probably we have an appetite for this to go well through 20%. But it is becoming a huge drag on the economy. So if we then look at global rankings, and this is from the World Health Organization, they have a matrix that does comparisons of a variety of measures of the quality of health care and the success of the healthcare system based on patient populations. The U.S. ranks about 37 out of 191 countries. There are some areas which we do better. The care process, we're fifth. But, that's because we have the mechanics for doing that within the various health systems in the country. But when we look at outcomes, it varies dramatically. So while we're spending a lot of money, we're not getting a real great value out of it because we're just not getting the results. And that, I think, is what has driven the past 2 decades of conversation about moving to value and changing the way we pay for health care. This is another way, a scatter diagram. You can't probably see it, but the U.S. is the lone dot, on the lower right, and the horizontal axis is spending, and the vertical axis is higher quality, and just another way of seeing that we are out of position with truly what's going on with the rest of what would be tier 1 countries. So let's get to how does that impact you and me every day? And one of the things that was spoken to earlier was wages. And wages have been flat in the U.S. and Idaho. Idaho is the lower line, but it parallels the U.S. It has been extremely flat for a long, long, long period of time. There's been a slight uptick as the unemployment rate has dropped. However, just because the unemployment rate is dropping doesn't mean that people are getting higher paying jobs. They're working multiple jobs to get by, but we still have a problem with this flat wage base. When we look at it in Idaho, and this is kind of a little bit of complex chart, but the 2001 is the lower chart. That was where, and we're using PPO costs. Insurance prices are a measure of, or mirror of, healthcare costs. So as healthcare costs change, PPO prices simply respond to it. And this is Idaho. And we saw that about 18% of total compensation was for the healthcare product in an employer-based environment. Wages were about $38,241, and then over the next 14 years, what we saw happen, this is going through the recession, this is going through all of the other issues that we all lived through. What came out of that was that wages went up on average about 1.8%, so about 26% over that 14 years. But the cost of insurance went up 193%. So what happened is we had this rapid expansion of healthcare expense through all of these years, and now we're looking at 34% of total compensation. Well, an employer has, a combined package of benefits and wages. And what has happened is, of course, the benefits continue to be paid for, even though more and more small employers are no longer offering group health insurance. It changed a little bit with the ACA, and there was a slight rise. But overall, employer-based programs were fairly static. So the third column is kind of a what-if exercise. So if over that 14 years we had been successful in keeping healthcare costs the same as wage costs at 3.3%, well, what we would have done is added an additional 24% to the wage base. And that wage would now be running right at $60,000, which, interesting, is fairly close to the national average we just heard about of $62,000. So had we been able to control healthcare costs in Idaho, then we would have all this extra income as a state for consumer spending, which of course drives the economy. And I think the point of this slide is, well, we can't do anything about what's already happened, but we can do something about what happens for the next 10 years. And the next 10 years will follow this pattern unless we do something different. So that's the reason that value-based is so important. That was one of the drivers when I was, with the health and welfare and Medicaid, to get positioned to where that block of business would move to value-based. And I think that is really the economic driver of why it is that we in the industry need to get this moved over. The other reason to care is when you look at bankruptcies, 62% of all bankruptcies in the U.S. are due to medical bills, and 72% of the individuals had health insurance. Back to the point from the earlier presentation. People simply don't have the disposable income, they don't have the savings that they're able to withstand these higher deductibles and higher out-of-pocket limits when they do show up. They just simply, the resources aren't there. So, in my opinion, of course, how we pay for care is really most of the problem. Because we know fee-for-service drives volume and complexity. Complexity is a very interesting issue because you see the coding come through, and the coding is actually for more complex services, and you wonder, what's real and what may be fiction. We know that providers who lower their spending, they're reducing their income. That's just the way it is, and there isn't much motivation on their part to do that. The other part is, as we try to measure quality, there doesn't seem to be, improved quality or effectiveness with this higher amount of spend. And we know that most physicians are making their decisions but have little information. The world of big data and data being available to health systems and to physicians has been elusive. For decades now, there's been hundreds of millions of dollars spent on big data systems, and so many of them have failed to deliver. Recently, however, provider health systems have been building their own with reasonably good success. And so I think this is now finally getting to a point of maturity where valid data on profiling of a disease load within a population is going to be meaningfully delivered. And then for some of us who've been in the insurance industry, we know the insurance industry has done their darndest to try to control costs, but it has been very, very difficult for them to manage. So when we look at Idaho, there are some good things, as well as there's some issues. We overall, based on the Commonwealth Fund, we perform better than we're probably over 2/3 of the state. So that overall ranking is pretty good. However, when you look at some of the individual issues, access and affordability is one that we suffer from. Access being, networks available, providers being available within communities. And we also know that there is an available load of hospital cost and use that could be eliminated. But again, that's based on a standard of saying that if you're a moderately managed or highly managed environment, that you could bring those down. Well, you got to get there. So saying it and doing it, two different things altogether. We do have good ratings for healthy lives because we tend to be a little bit better than most as far as exercise and activities. But disparity between the individual populations is a negative for us because there are certain people that simply don't have access to care because they don't have the money. Hopefully Medicaid expansion, hallelujah, will start solving that problem. So when we look at market solutions, and this legislature just loves to talk about market solutions. Of course, they don't spend a nickel's time looking at reality in Idaho when they do it. Because a market solution requires many buyers and sellers. Well, what do we have? 3 or 4 towns that have more than one hospital, and the rest don't and never will. I mean, that's just the facts of a rural state. So you don't have a lot of buyers and sellers, so you don't have that negotiation leverage. The availability of information really doesn't exist, so you don't really have buyers and sellers possessing the knowledge to make their purchases. And then we really don't have a way of calculating value. So a pure market-driven approach doesn't make much sense, doesn't work within an environment where you have too few of providers. Having come from the insurance industry, we spent years and years trying to develop benefit designs and utilization tools to try to control utilization. And many of them were successful. However, when you have a small percentage of the population driving a good portion of spending, and actually those folks spend so far beyond deductibles and co-insurance that really doesn't make any difference. They're now truly engaged in the delivery system, and the delivery system is going to be making a good majority of those decisions. Legislature likes to talk about skin in the game. Well, that works at lower cost levels, lower spending levels. But when it becomes serious, that just simply isn't a fact. It simply doesn't play into it. And we know that from the insurance industry side, we've put in prior authorization requirements. All were tools to try to control utilization, but overall has created a level of dissatisfaction between the consumer and the insurance company, because they see it as nothing but something in the road of health delivery. Physicians and hospitals have also been highly annoyed by it. So that technique has pretty much been used up. So why do we need a new system? Well, we know our system encourages spending. We need to, get quality and a lower cost underway, which we haven't been able to achieve. And that really motivates us to try and get to a different system, because if we want a system that behaves differently, then you have to change the incentives. Again, the current system works exactly the way it's engineered. And if we can't think we're going to just wish it to be better, we have to actually make the changes. And there are a number of health systems in Idaho that are well underway doing just that. And their percentages of value-based contracts are rising and will continue to rise as payers realize that is the true long-term solution for healthcare. And with that, I would like to move to our panel and have them speak to their experiences in value-based. We'll start with, I think I got this right. Who wants to go first? Dr. John Redding is going to go first. Just a little background. He is the president of St. Al's Health Alliance. He was appointed to that position in 2017. Prior to that, he did consulting work with many healthcare systems, using and moving them towards value-based reimbursement. He's a MD and an MBA from Emory, and with that, welcome.
Thank you. And thank you for having me this afternoon. So I was told that this crowd would probably be more interested in hearing a little about my experience in value-based care, both from St. Alphonsus in my consulting past, as opposed to a number of PowerPoint slides. So I'm going to freestyle it for you today. the first thing that I wanted to say is going back, as I talked about my background, prior to joining St. Alphonsus Health Alliance as its president, I spent a little over a decade as a management consultant in the provider space, primarily working on physician-hospital alignment, quality improvement, and then transitioning that into early in 2007, working in my first experience in building a accountable care organization and a clinically integrated network. And so from there, really went across the country doing that type of work. And so the first thing that I wanted to say is, in hearing Ian this morning and in having Dick frame us in Idaho, is that Idaho is certainly a unique and wonderful place, but in regards to the challenges it's taking on in healthcare is not necessarily unique in comparison to the other 50 states. But that being said, while we struggle with the same things, I will say from my experience in traveling across the country, it is quite progressive in where we've gotten given the community in regard to value-based care. We are actually doing quite well in moving down that transition compared to many communities that I've worked in. And I will say there's still for everyone a long way to go. There's a lot of enabling technology that needs to be available across the country, but we're actually here locally doing quite well. Now with that, a little bit about my role and what I do. So as the president of the St. Alphonsus Health Alliance, I am the president of both a clinically integrated network and an accountable care organization. And I think that those terms are used very differently in a lot of journals, in different conversations, and so it might be helpful for me to explain what that really means. And so I think the way that we look at clinical integration within the Alliance and what a clinically integrated network is really bringing providers and non-clinical team members together to coordinate care to improve value, and really looking at value as that equation of cost over quality in terms of clinical outcomes. And so that's really what we do. How do we need to focus to do that work? The first thing is we need to have a very comprehensive network of providers. In order to really coordinate the care, we have to be able to have the ability to really track and monitor and coordinate that care amongst all of the different components you need within the healthcare continuum. And so that means within the Alliance, we not only bring together the great providers within St. Alphonsus Medical Group, but the independent community and other providers as well as their team members, to really be able to make sure that as the patient goes from care setting to care setting, from provider to provider, we can really coordinate that as much as possible, because a lot of, I think, where we lose value in the healthcare continuum is really in those transitions. And so by making more effective transitions and sharing information and being able to track and monitor patient care across the continuum, we have an opportunity to inject value into the equation. The second part is that we have to partner with our payers in the community, and this is an area where I'll also say, in comparison to some of the other areas that I have worked, there is a real movement towards real collaboration with our payer partners in the community, whether they happen to be governmental payers, commercial payers, et cetera. But we really, as the network, have to make sure to work with them to establish value-based contracts that really provide incentives for all parties, including the consumer, to make the right healthcare choices and to allocate resources effectively so that we can invest in the change. And I think Ian was speaking about that moving into the future and moving into a real value-based environment requires change. And as we all know, change is very seldom free. And so in order to create those new skills, to bring on those new technologies, and to really enable a more value-based environment, we have to be able to resource and fund that appropriately. And so that is certainly working with our payer partners to really understand how do we appropriately allocate our resources and incent each other on the financial aspect to be as value-based as possible. I think a great example of this from what we've done here in Idaho is working with some of our close affiliates to really be able to understand on care and case management. We both have great resources. We both have great skill sets. How are we going to really align those skill sets and resources without duplicating the service, adding additional cost, confusing the patient, decreasing the experience? So really working with the organization to say, okay, how how do we bring our resources to bear in the most effective way? In some circumstances, reaching out from a provider organization really can engage the patient, can engage the provider. In other instances, the payer really brings a skill set that is going to be more scalable and more value in terms of engagement and outreach. In addition to that, what we have come to realize as well is that we need to support the providers in making this transformation. And so I think all providers by nature are really committed to providing the best possible care for their patients. But helping them understand how to do that in this new environment is something that we have to support. Really, everyone's commitment is to being able to help as many patients as possible. So all of the administrative work of trying to enable change takes away from that true initial commitment of a provider to the patient. So how do we facilitate it so that they can get the education and so that they can get the skill sets that they need to be able to function in this environment? And I'd say a big aspect that we see right now is really turning data into information for providers. I think that we have gotten more and more data available across the continuum, but really what to do with it is a challenge. And so turning claims into what are the gaps that your patients have and how do we prioritize those gaps given that we have finite resources, infinite time. So how do we do the most impact for the most patients within a given budget? And I think that's a really important thing in enabling providers change into this, is really identifying what those new resources, particularly technological, are available and then helping them use them. Also helping them understand what best practices are that have been demonstrated by their peers in sharing that, because we get very active schedules, and it's hard to find that time to truly collaborate with our peers and really understand what is working and what has been demonstrated as a best practice. So providing those venues, not only for us to come out and share what those are, but providing venues for the providers to get together, socialize, and share that and provide those best practices is very important. And then I think finally is really providing the glue for the overall patient experience, which is helping support the providers in caring for the patient between face-to-face encounters. And so this is absolutely critical because, as I said at the beginning, I think a lot of where the value is lost is in inefficient transitions of care. And so providing that supplemental resource that a lot of the providers don't have the scale, particularly small 1 and 2 provider practices that have the scale to really provide, so that when a patient transitions from the hospital back into the community, that they have the support. That if they happen to have a chronic disease and need additional coaching or additional management, additional enablement of managing their own disease, that they have that support, because otherwise they start to deteriorate and then end up back in the most high-cost sites of care. So I'd say those are the 4 things that, as a clinically integrated network in the Alliance, that we're really trying to do to enable value in this community, is make sure that we have that engaged network of providers that can cover the continuum, that we have contracts that really will inspire the payers and the providers to collaborate and to be able to make the investments we need to change, to support the providers in this new environment, and to be able to support the patients in between face-to-face encounters. I think one of the slides that Ian presented was really showing, where are organizations in regard to their commitment to value-based care. And I can say for both Trinity Health and for St. Alphonsus Health System, as well as the Alliance, we are committed to moving towards risk in a financially sustainable manner. And so when we look at that diagram that was presented, we're towards the left side of the diagram. The Alliance itself has over time participated in all of the manners of value-based contracts. We have provided care under what I would call pay-for compliance contracts of moving towards certain reporting requirements. We have provided care under pay-for-performance, which is really hitting certain performance targets. But a vast majority of our contracts at this point are really in the shared savings and share risk continuum, and that is both across governmental contracts, both across self-funded employer contracts, as well as Medicare, Medicare Advantage, and commercial contracts. We've actually been very blessed over the last about 3 or 4 years to actually have been able to be on the right side of the value equation on all of those contracts, delivering savings across the board. One of the areas that I think myself and the health system are most proud of is we actually participate in the Medicare Shared Savings Program as a Track 3 ACO. And we have, as part of a national Trinity Health ACO that includes 4 other regional health ministries that participate with us, we were able to have significant savings for the Medicare program through participation in this ACO. But we were also here in Idaho, and some of the other chapters are in New York and in Philadelphia and some larger markets. We were actually able to demonstrate being the most tightly managed ACO within that entire cohort. And so very proud of being able to do that here, knowing that we have a community that we can't pull as many resources out of. So we're having to innovate, and we're having to do so in a way that's really showing value. And then we've also had many local experiences as well in working with our local employers to be able to deliver shared savings out of contracts with them as well. So very excited about that. What do I personally feel are the components to delivering value? I would say it really starts with, as Ian said, that commitment to change and that commitment to collaboration. And from there, I would say that with that, it requires some curiosity and self-awareness. I think as an organization, we have to accept that we are in an environment of hyper change, that we are in an environment that is going to require us to try to innovate and potentially make some mistakes from time to time. And the thing is making sure that we are not too either cocky or committed to accept the fact that we may take a misstep from time to time, and being self-aware enough to course correct. And so I think that curiosity and self-awareness is very important. Effective engagement is critical, and I think that is both with the consumers and with and what I would call our patients, but then also with the providers. This is something that definitely on the patient side, we do partner with our payers in the community to figure out how do we best engage the consumer, because in some instances, as I've said, we can really do it on reaching out on behalf of the provider a little bit more effectively. In some instances, they really have better capability, and just really being very honest with each other about how we can do that most effectively. And then with the providers, this is just many times considered additional work for them. And so how do we really engage them? And I'll say the conversation around quality can be difficult at times, because providers truly look at quality a little bit differently than what is reported on various websites and on various scorecards. Is that providers, and myself included, are really trained to say that quality is long-term clinical outcomes. It is years of lives saved. It is diabetics that can avoid complications like nephropathy or having an amputation. We look at it a little bit differently. A lot of what is measured currently, because of I think part of it's the transition of patients that are in employers from employer to employer and insurance plan to insurance plan. It's hard to track the data over time. But a lot of what's tracked right now is really leading indicators of good long-term outcomes. And so it's also really having those conversations and really engaging the providers in, that, yeah, we're measuring quality today in an area that's a leading indicator, but really that we are also firmly committed to those long-term outcomes, and then how do we enable you to both deliver those, but then also demonstrate the quality that's leading to that in today's terms. And I'm very excited as we talk about some of the advancements in technology of really being able through AI and other things to really look at those long-term outcomes as opposed to some of the leading indicators, and being able to bring them together to see what really works and what really leads to the impact on value. And the last part, and then I will hand this over because I know I've been going on for a while, is really, I think, the enablement of non-clinical team members. And so I think that we've also discussed, and sometimes there's debate on this, but I would say in this community, I think there is no debate that access to primary care is something that is a challenge and will continue to be a challenge. And so there is the aspect of really changing the primary care model, enabling other providers to be able to support the primary care physician. But I think there's also a very important role for enabling the non-clinical team member. And so I will give one or two examples of this from recent experiences in the Alliance. One case study that we had is we actually had a team member that is on our performance improvement team that has no clinical background but has been working for practices for some time, that was working gaps in care list. And what they saw was the same name showing up again and again over a course of a few months in regard to hemoglobin A1C in control, because they were not in control. And so this non-clinical team member proactively decided that they were going to go bring this patient in a HIPAA-compliant manner to our care management team and identify this patient as somebody that might need a little bit of additional help. And so the care management team then was activated, did some outreach to the patient, and found out that the issue, that their hemoglobin A1C was currently at 14 when we're trying to keep that below 7. But then they found out that the issues around this were not necessarily what many times the community will say is, oh, the patient wasn't engaged. They let themselves go. But the reality is that the patient was in a situation where they needed a caregiver, and that caregiver was a family member, and that family member had burned out. They had been doing it for years. In addition, there was a difficulty in insulin prices had gone up considerably. Many of you may be aware of that last year, that some of the generics spiked. Insulin was an issue in being able to afford that, and so they weren't able to maintain their medication regimen. So through that, the care management team actually engaged some of our other team members, which was a community health worker, and that community health worker reached out to the patient and was able to help them get a waiver so that they could get some in-home assistance to take the burden off of their family member. And then we also engaged our PharmD, who was able to help the patient get access to some discounts to be able to afford their insulin. After working with our care team, and I think after a period of a few months, the patient was discharged from care management, and their hemoglobin A1C was down to 6.5, in control. And so the beauty of this story, in the case study, at least for me, is that, one, we really saw we often hear about in these talks, team-based care. For me, that's team-based care. And the part that I left out is throughout this whole journey that the team was in contact with the primary care provider so that they understood what actions were being taken. But truly team-based care. Then the other part that was beautiful for me is the vision of clinical integration and accountable care has always been practicing to the top of our license. And so in this case, we took somebody with no true clinical training, but with experience in the clinical setting, and made it so that they were able to identify and help a patient that needed care and affect a significant change in their health status and their ability to care for themselves, as opposed to it having to be driven by the physician themselves. And so I think in this environment where we will be continuing to struggle with primary care access and where we will be evolving the team, that the really exciting part and opportunity is enabling some of these non-clinical care providers or care team members to really make that impact in patient care. So very excited about that. And then I think the one other learning that I will say that I've had over the last few years is, and that we have integrated into what we do, is really embracing the fact that what we do as providers in genetics only really affects about 30% of the overall health status of a patient. And so understanding that we play a role, but we really have to identify other things around behaviors, around social influencers of health, to really fully get a patient to optimize their health status. And so we have, over the past few years, been increasing our commitment to a team of community health workers that really goes out and helps identify with patients that have a little bit of extra need, what those needs are, and identifying ways to help them more effectively engage with the health system. Because oftentimes, like in that story, not having a family member that still had the energy to provide care was really inhibiting the patient's ability to care for themselves. And so using that community health worker to find a resource to be able to help was very important. We had another case where we had a patient that had actually been discharged from the primary care panel because they kept on missing their appointments. The issue was not a lack of engagement. The issue was that the family member was charging them $50 to drive them to the appointment, and they couldn't afford it. And so when we found that out, not only was the Alliance able to, through the care management team, go find another primary care provider, explain the situation to them that wanted to take on this challenge, what we thought was a challenging patient, which ended up not being a challenging patient. It was just about getting them transportation. But then once again, to engage a community health worker to help them find a way to get transportation to their various appointments. And once again, ended up in having a significant improvement in this patient's quality of life. So I think oftentimes we talk about value-based care, we talk about clinical integration, the terms can feel pretty cliche at this point, but I think that's what it really means to me, is affecting these patient outcomes in a collaborative manner, in a coordinated manner that ultimately improves the quality of life and the clinical outcomes of the patient. So I will stop there and hand it to our panel.
Great. We'll come back with questions, so make some notes. We'll come back and you can ask questions of the panel. Next, Lisa Hettinger. She's Deputy Director in the Department of Health and Welfare. Her responsibilities include Medicaid, public health, behavioral health, and the Office of Health Care Policy Initiatives. She's got an MBA in Business and Healthcare Administration, so Lisa.
And if I could, I'm going to actually reverse what you just said in regard to taking questions, because I feel like if I go into my spiel, we're going to start to see some heads drooping. So I would love to just take an opportunity, because it will also inform some of my comments, to perhaps yield to the floor and give everyone the opportunity to ask any questions that they have of Dr. Redding at this point. But I will also invite you, when I'm speaking, to please stand up and move to the mic and ask questions as they occur to you, because I certainly don't want to cut us shy of the time to ask some of the pointed questions that all of you may have about value-based purchasing in Idaho. So I'm not seeing anyone leap to their feet.
So while you're all rushing to the microphone, Dr. Redding, there's often been a conversation about organization culture, and you talk about non-clinical caregivers engagement. Could you talk a little bit about how you've engaged with physician staff to be more readily acceptant of that engagement by the non-clinical?
Yeah, I think that it's, as you said, it's a shift. It is definitely a shift in culture. I think that there is often the concern that putting things that have a potential, I'd say maybe even tangential to clinical focus, into the hands of a layperson puts the patient at risk. And the reality is, and I think I always like to make a plug for this book by Clay Christensen, called a Harvard professor that has done a lot of work in innovation, called Innovator's Prescription. But I think that this book lays out a lot of the ways that healthcare can, both the clinical model, the business model, the regulatory model, et cetera, can change to move us into more value. But what it does call out is that the fact is that we are developing more and more medicine that is not necessarily experimental, but is relatively predictive, if not prescriptive. And so there are many things where there are algorithms that if we follow them, we will see various outcomes occur. And so I think one is really engaging the team members in that fact that there are, making them comfortable that there are a lot of very good scientific algorithms that can be utilized. The second part is just building the relationships and the trusting the relationships to help the team members that are in the practices understand that we care about their patients as much as they do, and we care about them, and we really want to have optimal outcomes. But then also framing it in the fact that it's an issue with time. The one resource, and you've probably heard it before, that you can't get more of, you can't pay for more of, is time. And so, frankly, adding value in many times requires some time and investment and change, but then also sometimes some additional layers and steps that we have to go through. And so, frankly, helping the team understand that we're able to have other resources and to help supply some of that time so that they're able to do areas that really do require that in-depth clinical knowledge, and we can take some of the more algorithmic things off of their hands. But frankly, it does take a while to get there. I think we've been lucky with the Alliance. We've been working with the provider community in this clinically integrated structure for, I believe, 6 or 7 years now. And so we've gotten to that point where we feel that we have very functional relationships with our practices, and they understand our role and understand that we're not going to cross boundaries that get into that space that really require that very in-depth clinical knowledge.
Thank you. Other questions? There we are.
I've got one. This question is for Lisa. I'd just like to hear about where Medicaid is at in terms of paying for value and where we need to go.
Fair enough. So I will go ahead and do my part of the presentation. So when you look at what the conversation I'm about to have versus my full scope of responsibilities, I do want to make sure that I point out at this juncture that the conversation is about to turn and has been probably partially in the financial space at this point. And certainly that's an important angle to have as a payer, and it's sort of a necessary way to dive into when we're talking about value-based purchasing, the conversation. But I want to just have everyone in the audience know that while I'm not going to be devoting time to the subject, that rest assured, one of the department's commitments is that we are actually looking towards social determinants of health as being one of the things that we have a large role to play in the environment, but also the way we're structured, where we have the Medicaid budget, the behavioral health budget, and the public health budget all working together in concert. We also have unique opportunities that other states don't have to truly move the dial in areas that don't have to do with how much is Medicaid paying for a surgery. So I wanted to preamble to let all of you know that despite what's about to come, that is a key overarching goal of the department and of mine with the divisions that I work through. So moving on to what we're doing in value-based purchasing. One of our strategic objectives at the department that is laser focused on the Medicaid program is that we are going to be promoting healthier Idahoans while increasing healthcare quality and reducing cost. And as everyone in this room knows, that is a dense statement, and there's probably a lot of unpacking to do. So I'll skim through some of the unpacking and then see what questions you have so that I'm not directing the areas that you might have interest in more information. So when we're looking at that, Medicaid has taken the very clear path of saying we want to approach payment reform to deliver managed care without restricting access. One of the things that Medicaid in Idaho must have a laser focus on is the fact that our state in general is an access problem state. And I'm not talking about just the Medicaid program, I'm talking about our entire state. And so it was beholden upon us that we create reimbursement reform in a way that we weren't going to make that access problem even worse, which meant that it had to be done collaboratively, that it had to be done with the providers and other partners at the table, letting us know exactly what the pain points were of historical approaches to payment reform and exactly what was working. It was also done with an eye to the national conversation and the national approaches that have been piloted that have delivered the best outcomes. And so when you look at what we have done to date in the managed care space, we currently have risk services provided that are overseen and administered by insurance carriers in the areas of our dental benefits, our outpatient behavioral health benefits, our non-emergency medical transportation benefits, and then comprehensive services for health services for all those who are eligible for both Medicare and Medicaid. We call them our dually eligible population. We also have a very robust and well-supported primary care case management program, which is serviced through the Healthy Connections providers that we have throughout the state. And this program is leveraging the patient-centered medical home model of care to reduce the total cost of care. And I don't say that as a theoretical statement. It has very literally been able to deliver to us a bending of the cost curve in a way that probably none of us actually imagined, because it happened not quickly, but on the scale of the way healthcare change happens, relatively quickly, and it has held its own over time. And so that reinforced what we were hearing from the provider community and what we were seeing on a national level that was saying, we have got to have a more robust engagement at the primary care level with patients to truly start to bend the curve in regards to a lot of the heavy cost drivers that are in the system already. So that is the approach that we have used to date. We've been incredibly fortunate to be part of a larger conversation that has happened over the past 4 years, where we were implementing a pilot to actually operationalize our state healthcare improvement plan. And that work was done in the room with just about every type of stakeholder that is engaged in improving the health of Idahoans and trying to make it more affordable and accessible. We have ended that period, and we are fortunate to still be at the table with the group that chose to continue that work in the absence of what was a very large federal grant that helped to support some of the infrastructure building and administrative support that is not traditionally funded by the payer community, and in particular in the Medicaid as a payer, because our reimbursement is, nobody will deny me this one, low in regards to commercial rates. So all of these conversations have informed what is the right next step for Idaho Medicaid to take in the at-risk space in moving to value-based purchasing. And the step that we have already entered into is we are moving into some total cost of care models. And those total cost of care models are ones that we are currently crafting contracts directly with providers to engage in, and they actually are risk-based contracts. So one of the things that our first speaker mentioned was that we have this space that folks tend to play in where it's fee-for-service with tricks. And certainly that has the ability to help improve the quality of care, and at least the quality of care, and sometimes the cost of care. But it has not really delivered measurable improvements in making care more affordable and have better outcomes. So what we're trying to do is say, we've all watched these things happen, and for some of the providers, they've had the pleasure to experience it firsthand. How can we take a more holistic approach to this question? And that's why we looked at, after this 4 years of foundation building that were done with the SHIP, allowing a lot more providers to get the types of foundational tools that they will need to participate in legitimate value-based purchasing. We are now entering into the realm of this total cost of care program with the downside risk. Now, entering into any conversation, there's always a question with Idaho Medicaid about whether we should enter into it at a statewide level, or should we be entering in a more regional manner. We entered, as I'm sure all of you are aware, with our outpatient behavioral health contract at a statewide level. And there were reasons for that decision at that time. However, with this model, what we noticed when we were looking at our physical health expenditures is that there were 4 very distinct regions in the state, and they performed very, very differently in the space of outcomes and total cost of care. And so we are taking the approach where we are going to allow them to have individualized approaches to a total cost of care model, and it will work for them in a way that best suits their provider community. And so I say that because I'm about to tell you a little bit more about one region, which is the first one that we've entered into, but I want everybody to remember that despite the approach we are taking in this first region, we will and plan to develop a program that has the same goals but works for the providers in the other regions of the state based on where they are in delivering some of the foundational elements that you talk about that are make a value-based purchasing structure successful. So within the Treasure Valley area, the greater Treasure Valley area, we have engaged in conversations that are allowing for a couple of different models of total cost of care risk-based contracting. And one of the models is an ACO model, and I want to be very careful to let everyone know that when we're talking about an ACO model and we are Medicaid, a lot of people instantly jump to think that we are adopting the Medicare ACO model, and that is not the case. We are using the term in a very scholarly way to say that the accountable care organization that we're looking for intonates a vertically integrated system approach to care, rather than the exact financial arrangements, because it's the financial arrangements that we are currently in negotiations on in the Treasure Valley. The second piece of that Treasure Valley approach that we're taking to a total cost of care approach is we are working with the primary care physicians or the clinics or some of their associations in developing a path for them to engage in the space of risk without actually necessarily being contracted within a fully vertically integrated accountable care organization. It still imposes risk on them. It still asks for exactly the same quality outcomes, well, not exactly the same, but within the sphere that is shared between an accountable care organization that contains a tertiary environment and a primary care environment that's not vertically integrated, where obviously they have, in some cases, very little control over the quality at the tertiary level or the secondary level. So that, like I mentioned, contract is in negotiations. We are in the phases of it where we are working through the financial calculations, exactly how they will be calculated. As those of you who've entered into these conversations, this is where it starts to get a little rough. And we are hopeful that we will have those contracts signed in short order and that we can start moving towards full implementation in the Treasure Valley. Simultaneously, because physical health, while it is about 50% of our expenditures in Medicaid, it is only 50%. And if you look at all of the services that we render in a space called long-term services and supports, it's a fairly unique space that Medicaid occupies in the payer space, which is really to say that we are looking at 50%, approximately just shy of 50% of our expenditures, or at least our second biggest bucket of expenditures, are paying for these services that are provided that allow the disabled to live in the community. And so while we are heavily engaged in the conversations to start this new total cost of care program that will start to move the dial, we are also heavily engaged in the work that is addressing the expenditures and the growth rates that are happening in the other book of businesses that we have, and in particular when we're working with the disabled. So another brand new thing that we are just engaging in, and some of you may already have experienced this in your communities, is that I'd mentioned earlier that we have a product that provides comprehensive services for those who are both Medicare and Medicaid eligible. And just in the past year, we were able to get a second payer in that market, which allowed us to have that program become mandatory. But almost more important than that, it allowed us for the first time to ask of those two insurance carriers that they also take on risk for the long-term services and supports that are rendered to these dually eligibles. And that is a really big leap in this space. I can't really speak enough about what a huge transition that is for the state of Idaho. So we're very, very proud. Our business partners have been phenomenal in this space. We also took an iterative approach to that, which is we are starting in community by community, sort of pocket by pocket, to make sure that everything is working perfectly. Because all of a sudden, rather than just dealing with physical health, which is a very big deal and can be life-changing for many individuals, we've just thrown in where they live in a very literal way. We have thrown in the fact that we engage in a space which allows them to live in different environments. And if something goes wrong with bringing the managed care conversation into their living arrangements, it has very disastrous consequences for an already extremely vulnerable population. So again, the iterative approach is meant to ensure that the business model is sound, that the providers that are in those communities are fully engaged in the change that's going to be necessary for them, and that we don't wind up with any disastrous consequences for any of our participants. And what we're looking at also in the what I would call the near future, I won't bore you with a long version because I think that some of the details you're interested in are more in this right now space, is we are looking at not looking at, but we are actively preparing to start looking at a bundle or episode type payment for specialty services, and really hoping that we can start to move the needle on expenditure growth in that area. And in all of these models, when we're looking at these at-risk environments, it is our goal to remain a partner in risk with the provider community. So in other words, rather than a couple of the managed care contracts that we have already negotiated, with these new arrangements that we're making, the future arrangements, we are splitting up the necessary pieces of good managed care between us and the providers so that everybody is working within their core competency, and not trying to say that Medicaid and nurse reviewers that we may hire should be the ones making utilization management decisions, but rather to say that providers who know that patient well and know the full environment of that patient's care should be making those choices, but that we can't enter into that space willy-nilly. There has got to be some risk involved, or what we're really doing is putting taxpayer dollars at risk. So that's why the program is designed in such a way that we remain as partners at the table, but the other partner does need to be in that risk arrangement to ensure that we are not doing anything that is foolish. And there have been, over the past 20 and 30 years, I think you've probably all done the studies, a lot of attempts at managed care that had very disastrous outcomes for either patients or for the actual amount of money that was spent on the system. So all of this is a lot of information, and I'm going to pause quickly at this point to see what questions folks may have, and then if we don't have any questions, I'll go into a few more details.
We have heard from Pocatello. 2 questions. I was wondering if Dr. Redding could expand on the contracts / systems in place that allow pharmacists and other members of the healthcare team besides physicians to be paid through insurance for their services and contributions to patient care, as well as whether or not any of these services take place outside of the hospital, like at a local pharmacy.
So to answer that question, with the Alliance, we do not bill for the services of the extended care team. So really, that is the model, I believe, of having a shared savings or shared risk agreement, is that the financial arrangement is that by optimizing our resource utilization and increasing value, there should be, in optimal circumstances, additional dollars available to the network. And so we utilize those resources that are coming in through non-fee-for-service type of payments to then staff those roles like community health worker, our pharmacy and medication management team, as well as our performance improvement team. So it's really, we are vested, whether we're in shared risk or not. We're really in risk even being in shared savings, because we have to fund the care team up front in order to generate that value. So we are not charging for those services other than to improve the overall value of care.
I believe this question is for either or both of you. What actions have you seen to effectively involve independent providers in rural small communities into a value-based system with the proper incentives?
That one once again, that went a little fast.
I can read it once again, I can't explain it. What actions have you seen to effectively involve independent providers in rural small communities into a value-based system with proper incentives?
Do you want to go first?
Sure, I can start with that. I think the most important aspect is really, I would say, the engagement and education. So, I mean, with our network and many other clinically integrated networks that I've worked with, the geographic region can be relatively broad. Typically will include some rural providers, if not, in some of the communities I've worked in, it's been mainly rural providers. But it's similar principles in the fact that there is a good deal of education that needs to occur. There also needs to be some innovation on the side of how do we coordinate that care from a distance. When you're all within a concentrated community, it's a little easier to have those relationships. So how do we facilitate those relationships? I will say certainly the utilization of technology helps, so using telemedicine as well as just other communication tools between provider and provider to do that. But it also takes a commitment from the network, for in this case an ACO or clinically integrated network, to get out and spend some time with the providers in that community to truly engage them in the model, and also to understand where the traditional model we're using doesn't work for them, so that we can go back and think about how we might make some or retrofit some solutions to make it so that everybody can have access to similar resources and provide a similar level of care. So to some extent, sweat equity.
And I'll speak from my perspective, from the Medicaid perspective. One of the reasons that we looked at a regional approach for a total cost of care or a value-based purchasing environment was we absolutely had to make sure we took into consideration and provided the right model for our rural communities. And really, when you look at our urban centers in Idaho, they are far less urban than most states, so several approaches that a lot of states have used in this space are not going to work, frankly, in Idaho, and will actually restrict access to care and have the potential of putting limited providers, maybe not out of business, but at least out of the Medicaid business, and we really couldn't afford any of that. So the things that we are weaving into our design program to address the rural provider, the small rural provider consideration, and I'll be honest, we aren't aware of many other types other than small rural providers. And when you look at some of the things that they need, a couple of things are important. One is that we all stay engaged in a feedback loop. In other words, that we are continuing to get feedback from those rural providers about what they need to better perform in a value-based structure. Some of the elements that we've designed in this program, though, to date, based on the feedback that we've had, are that they will be looking to us to help them with what I'm calling value statements. That seems to be the term on the street, at least in the Medicaid world. And value statements are meant to encapsulate for those who are making referrals, so now we're talking again about those small rural communities, in where they should make the referral based on high quality care that is at a lower price point within the Medicaid expenditure world. And in the absence of that, rural providers really often they are very far removed from secondary and tertiary care and don't have a lot of knowledge about what value-based referrals even look like. And so that's one of the things that the Medicaid program will be providing them. Again, it was a requested tool from all of them. Another piece has already been mentioned. I think technology is still underutilized, but I think part of the reason for that is the third piece of feedback that we received, which is in a fee-for-service environment in a small rural area, they are hard-pressed to create the resource infrastructure to invest in their time. So even if for whatever reason the technology doesn't have an additional expense for them, they need to commit time to using that technology to make these improvements. And in a fee-for-service environment, they can't. They are absolutely at the end of their rope in terms of the reimbursement structures. And so their request, and this is a bold move for them to ask for this, but it also indicates their willingness to change, and I realize I'm making huge generalizations about all rural providers, and I apologize for that. I realize that everybody's in a different space, but with those that are really engaged in wanting to participate in value-based payments and wanting to work at the top of their licensure and improve the outcomes for their community members, they're asking us to move their payments away from fee-for-service and towards more of a per member per month arrangement. When you are a primary care physician group, saying that you're going to be fully capitated for your lives is a bit out of your grasp. However, if we can start to shift the balance to downplay the fee-for-service part and emphasize a per member per month when we're looking at care coordination and case management, that has been their ask. And our ask in turn for that is that they make themselves available and accessible to the larger healthcare world. In other words, they do at least engage in enough technology that they aren't an island, that they have information about folks that come into their clinic who have received services in other places, that they be connected electronically to the larger healthcare space. And the reason Medicaid has asked for this is, in particular, our population is quite mobile, both in terms of where they live and where they may seek care, but also in regard to when they are a Medicaid participant and when their economic situation changes and they aren't for a time period, and then they may be back again. And so if we don't have the rural providers engaging in the larger electronic health record space and getting clinical information about these folks for a period of time when they may not have been within the care of that primary clinic, we experience as Medicaid, and this is a national problem, a higher risk of adverse outcomes. And so that is our ask. We will help you and walk with you into the space of taking on a little more risk, giving you a little more risk, increasing your per member per month, reducing fee for services, but we need you to be fully engaged in that patient, which will involve technology.
Thank you. Another question.
Yes. With regard to the value-based care that has been spoken about, my question is, or rather I believe that it's important to train the future workforce in providing the value-based care. But if we don't have a good understanding of what it is that we mean by value-based care, then it becomes difficult to be able to put together the training that can be provided to the future primary care providers to prepare them to do that. From your experience being in the field, how would you define or describe what we mean by value-based care? Because a good understanding will help the teaching or the putting together training that will help prepare the future workforce to be able to do that when they get into the field.
Well, I will give hopefully it probably will feel like an overly simplistic answer, but I actually had the opportunity to speak with somebody about this 2 days ago. So I've formulated some thoughts on this. But so my background is I actually, in undergraduate, got an economics bachelor's degree, and then followed up with my MD, MBA from Emory. And through that, as I reflect back on what has been required for myself to get a vision on value-based care and to develop kind of the skill set and the skill sets around me to deliver on value-based care, it actually comes back to, I think, something that Ian hinted at, which is injecting traditional business principles into healthcare. And so I would say the training that I got that helped me was really applying the fundamentals of my MBA program. And as I went through that, I really focused on, if I'm looking at Lean Six Sigma and I'm looking at queuing theory, then let me apply that to how we need to build an emergency department so that an individual does not have to wait more than 30 minutes to get or an acceptable time frame to get into their to see the physician. And that can be applied to a primary care office or any place else. So I think that in value-based care, there is certainly a supplemental layer of understanding value-based reimbursement models, understanding I would say healthcare pricing, understanding just clinical workflows. So there's this layer of healthcare that has to go on top of it. But I truly believe that a very strong background in the general business principles of cost accounting, of Lean Six Sigma, in analytics, and I cannot emphasize going forward how important analytics will be. And so having a very strong analytical background is going to be absolutely fundamental as well. So I think that would be my advice in building the workforce is get people that have a strong commitment to both understanding the fundamental principles of business, but also committed to translating that into a healthcare mindset. So that has that passion around healthcare. So everything they think about analytics is how am I going to apply that to the healthcare perspective. So I think there are some supplemental classes, but I don't want to dissuade from just the core.
And I'll make a quick comment in this space that goes just a touch beyond the training, which is a huge component of this. You're absolutely right that physicians that are coming into this space perhaps for the first time, or who have been in this space for a long time and are being forced to change, they are all needing to learn about the core tools that help you to properly engage in value-based purchasing. Analytics is mentioned, but there's a list of 4 or 5 items that are within that. However, I think that another thing from a payer perspective that we can do to enhance that training and learning is we need to make this not as hard as payers. In other words, there are things we can streamline if we will just engage in conversations together. Not talking about anything in the antitrust space at all, but simple things like quality measures. And the great thing about living in Idaho, and this is unique in the nation partially, you talk to other states and they're astonished that we have this kind of a work group put together, is that we actually do have robust participation in these larger environments that I mentioned. I mentioned earlier the Idaho Healthcare Coalition that was working collaboratively during the SIM grant, but then also now the Healthcare Transformation Council of Idaho. And one of the things they tackled, it sounds small, but it was huge, was coming up with a list of shared quality metrics and then getting far enough down into the weeds that literally we were all starting to agree to measure those things in the same way. So using the same underlying data points so that we actually made the provider's ability to engage in value-based purchasing easier. And so those types of activities are ones that the payers can undertake to better enable providers to deliver on what the outcomes are that we're looking for.
Thank you.
I do want to supplement my answer with one aspect, and that is change management. So I think absolutely, in addition to the core, is really in this environment, having a very strong practical knowledge of change management is going to be important because there is so much change at so many levels going on. So really being able to engage means not only being able to lead that change, but having a certain level of change tolerance and resilience. So I would absolutely make sure that that is part of the training for providers, administrators, nursing professionals, et cetera.
Hey, one more question, Tony.
Thanks. I want to talk about mental health and where this fits in this category. And I don't know, Dr. Redding, if you could talk a bit about where mental health fits into your coordinated care program or integrated clinical care. And then for Lisa, at the state level, if we have mental health is a separate contract statewide, and ACOs are regional contracts, looking at regional programs, how do we integrate those two? What's the future of those programs? How do we bring that all in? How do we make sure mental health is part of all of this?
Well, I think, we are, behavioral health and substance abuse is certainly a challenge, I think, for all of organizations in the accountable care field. We are well aware that the patient population that has a mental health diagnosis or substance abuse diagnosis can tend to actually cost for the same otherwise clinical background 3 to 4 times what the patient without that diagnosis will have. So successfully addressing behavioral health and substance abuse issues is critical in a value-based environment. I think one of the aspects is we certainly all struggle with access. And so, part of this is really being committed to developing and that workforce that can address this. The other aspect, I think, is really the integration into the care team. As you implied, it can seem like a bit fragmented. Often the providers, and I wouldn't criticize anybody for this, but I'd say the behavioral health and substance abuse issues can both be things that are uncomfortable at times, and also with still having, as some people put it, having a foot in both canoes in the productivity-based model, as well as the value-based model, can be difficult to dedicate the time to really be able to fully address the behavioral health and substance abuse issues. So I think that's an area where, as a clinically integrated network, certainly we have a community health worker team in our team. We also have social workers, et cetera, but it's really expanding those, and then also really further working with how do we more effectively direct people to other community-based resources that they can utilize, and then how do we coordinate with them so that it's not just a handoff, but it remains within that team-based approach. And I think we've done a great job of expanding the care team locally, but there is ample opportunity to continue doing that with external agencies that don't need to be external, that we need to pull them inside of the overall care continuum within the Alliance and other organizations.
And I'd answer that question by talking a little bit about the different levers and dials. We have a very different system of levers and dials than commercial programs do. Frankly, it has to do with the population we serve, some of the things that we have been handed that are advantageous to us. For example, the reimbursement structure that's been handed to us for pharmaceuticals is very unique. But in this environment, we also have more services that are available to participants who have behavioral health needs, and we have quite a bit of control over them. So in terms of blending what we have right now, which is managed care for outpatient services in the behavioral health space, with a regional concept within the physical health realm, the particular levers that we have for both of those realms that can be aligned are ones that are part of our 5-year transition. Generally speaking, in our 5-year transition, we're going to start holding the insurance companies that have these managed care contracts accountable for the same quality measures and the same movement of providers into risk arrangements that we are when we are engaged directly. But specifically within the behavioral health space, I'll go back to a comment you made earlier, that the biggest problem that we see in the environment is transitions. And so what we've been doing over the years with our outpatient contract is increasing the amount of pressure that is on the measure that says that they are to be engaged with a inpatient stay in order to transition somebody into the correct outpatient services, which goes in tandem with the fact that they have measures that are within their contract that ask them to increase access to outpatient services and increase the array of outpatient services. So by making sure that we have the same goal for the contracts we're writing on total cost of care with the ACOs and with the primary care physicians, in other words, that there be demonstration of an active engagement and follow-up to ensure that as somebody is transitioning from a more intense level of care into one that is more of a management phase, that people are actually getting the services. They are very literally showing up at that provider of service. And so that's the way that we intend to help with that gap. But I'll make one quick plug. It is our dream that we will wind up with a whole lot more primary care clinics where behavioral health becomes an integrated service in part within that clinic. That would be our dream of how we could truly integrate the two.
Okay, thank you very much. Thank you all for your participation. I think that ends the session, sir.